So patient is ready. Draping was done. So I am going to start. So I am taking the cables. So cables are attached. I am not taking the socket tube because I am not expecting any bad appendicitis. But taking the socket tube is not a bad idea. You can always attach the socket tube during the appendectomy, whether it is simple or complicated. And previous one was recurrent appendicitis, so I did not expect it to be grossly inflamed or something like that. So I have used 5 mm. It is acute appendicitis, no history. At least they are not giving any history of previous attacks, but you do not all the 5 mm here also. But if necessary, I will replace the 5 mm port at the umbilical site into 10 mm. Okay, so we have created the port site. The 5 mm trocar I am introducing into the peritoneal cavity first. The gas line is attached. Gas is kept like in the previous case, 12 and 3. 12 millimeter mercury pressure, 3 liters per minute flow. Now I am preparing the telescope by soaking into the hot water and cleaning the back of the telescope and cleaning also the camera head because it has already been used in the previous case. I am not sure how clean it is. So attaching the light cord, if you can see, I think it is okay. So here inside you see some blood. It is from the port side. It is not to be worried much. Gas to on করনি my sister has forgotten to start the gas. Now they have started, so we have to wait for few moments to distend the abdomen for at least a little so that we can see the inside. You see, sometimes this happens. The incision to create the port site sometimes give us some difficulty. You see, the gas is going a bit slowly. That is why no problem. We do not need to rush. So this is the left anterior superior iliac spine as it is a younger in any female patient, whether child or adult, may expect the ports below the bikini line. Although in our country it is not that much important because ladies usually do not go out wearing bikinis, but they may prefer an invisible scar. So we can comply to their demands. So all the ports are in place, all are 5 mm. Now we are starting our actual job. The Babcock forceps in the okay. This port probably has come out, so we have to push it again. Okay, now we are ready. The pelvic cavity we will check. The ovary, right ovary is normal. This is the uterus, and here is the left ovary. I am not sure. They did not give any ongoing menstruation, but the blood from the umbilical port would not have created this collection of blood here. Could be retrograde menstruation. Okay, so we will look into that later. You see the momentum is in this region, probably due to inflamed appendix. Here is the appendix. You see the tip of the appendix is here. You see, it is genuinely inflamed, right? It is genuinely inflamed. The tip was residing in the peritoneal cavity, pelvic cavity, like this. So we will do the skeletonization, hold like this near the tip. As there is some serosanguinous collection in the pelvic cavity, we will need the sucker tube, but may not need the sucker machine. Sometimes siphoning will clear this area. If not, we will attach the sucker tube, no problem. I don't want to go further down right now. Clean. During my assistant is cleaning the telescope, I will attach the sucker tube so that we can give a little normal saline wash at the end of the operation, because blood is a bad thing inside the peritoneal cavity. My the port at the umbilicus has some problem with its valve. So a lot of gas came out when my assistant pulled out the telescope. That's why we need little time to distend the abdomen again. তো দূরে রাখো না টেলিস্কোপটা. You see the fogging is happening very quickly. Sometimes this sort of problem happens and you cannot see এটার ডুবাইলে দেখো তো এটা আসে না, বুঝতে হবে তোমাকে। These are some technical problems you may face during any operation, including in laparoscopy. You see the gas, we have lost some gas during, and what I am now doing is trying to coagulate as away from the telescope tip as possible, because if the telescope is close to the coagulating area, there will be more fogging due to generation of the heat with the gas, generation of the heat at the tip of the telescope and diathermy. So creating the window now, then parallel to the appendix body, you see, keeping the tip of our hook parallel to the body of the appendix. And in this case, the appendix is somewhat inflamed throughout. So probably we will introduce a 10 mm before retrieval, so that it does not touch the port side of the abdominal wall. So the little on the basal aspect we need to coagulate again. There was some blood on the tip of the telescope, so visualization was compromised. So we are now okay. It is now clear again. So you see, the most of the dissection is completed. Here is the base. This is a very thickened area. We have to proceed carefully. Do not want to go the whole length at a time. So little by little. This is the base. This is probably the appendicular, main appendicular artery. So we have to be careful here, so that there is no bleeding, as well as there is no injury to underlying gut lobes. Burning close to the appendix wall. Only the appendicular artery for now. Then When it is divided, we will go further down. Jafar, are you there?
Yes, sir.
You can see what I'm doing.
Yes, sir.
Okay. So it is one difficult case, we can say, right?
Chicken chilo,
It
sir.
is thickened and appendix is inflamed, and still there is some bleeding from the port side. That we will manage during port closure. So you see, I think appendicular artery has been divided. Now we can go towards the base. There are some adhesion near the base also. You see, this is adherent to the abdominal wall. So we will divide these adhesions, release these adhesions. You see, the adhesions are released and appendix wall is visible. Okay. In this part also, we will use the bipolar again here. Okay, we are near the completion of the skeletonization. Keep close to the appendix wall so that inadvertently you do not burn or perforate or divide any other structure. I think base is a bit. Here is the base, so we need to release some additions here. I think it is okay, Jafar.
Yes, sir.
We can ligate here. Only use the bipolar for those spots, red spots. Okay. So we'll now ligate the base of the appendix, then clean the pelvic cavity of serous fluids, give little normal saline, to clean it properly. Then we will divide and bring out the appendix. Okay. So make sure it is at the junction of the appendix with the cecum, so that there is no future probability of stump appendicitis. Okay. If you feel difficulty, you can introduce another port so that your assistant can hold the appendix, or there is a technique I have described, the sling. You can create a sling in the abdominal wall and hold the appendix within the sling so that appendix remain straight, and in that way you can clearly see the base of the appendix. Now we will clean the little collection here. সরকার কি কানেকশন দেয়া আছে? Very little collection.
Yes, sir.
I do not want to introduce any non-saline, or a little amount I can give, so that the blood staining goes away. Staining is not a problem. Little amount of blood may lead to future adhesions. So you see, there is no ongoing bleeding, just little. And do not worry if you cannot suck out all the fluid. Most of the around, if you keep at around 400 ml of fluid, normal saline in the peritoneal cavity, it will be absorbed within few hours. Okay, so we are now what I have said, but that we can change the port site, ports, the umbilical port into 10 mm, so that the appendix body does not touch the skin and subcutaneous hole during retrieval. Okay, so my assistant will show me the site. You see the clotted blood. You can see the tip of the 10 mm. Okay, it has entered easily. So now we will use that port to bring out the appendix. The look of the appendix is almost gangrenous. You see, the what we usually do is milking from the base to clean the area of division of fecal matter. Cut part of the wall, not the complete division first to keep the traction. Give some coagulation to the divided part. Now we'll complete the division, and as the port site is now wide, that is 10 mm, it will easily enter, you see, into the port. So there is no chance of touching the abdomen wall and releasing the gas. Okay, so I think our principal job is done. Now we will close the abdomen.
আর এটা পরে বের করছেন 10 mm পোর্ট দিয়ে না স্যার?
10 mm, right? Because the abdomen was almost gangrenous. I did not want to touch that appendix into our port site,
জি
which
স্যার।
may lead to port site infection. Okay, so
জি স্যার।
in this situations you can use 10 mm. I have completed the operation using the 5, but just before the retrieval I have introduced the 10 mm to avoid contamination of the port site. Okay,
জি স্যার।
that is you can remember. And if you I could have done the entire operation using the 10, but I have waited, as I said earlier, that it is acute case, so it was expected to be in this condition, right?
জি স্যার।
You can do the entire operation using the 10 mm at the umbilical site. Okay, I just uh, did it using 5, but that is not necessary. So our principal job is done. Now we will be closing. And as I said, if when I can prepare the forms, I'll send and fill it up. There will be 3 forms, so you will have to fill up 3 forms and then send me. Okay, thank you, Jafrul. Bye.
আসসালামু আলাইকুম।
If there is any more operations, I will let you know.
স্যার।
Okay, bye.
আসসালামু আলাইকুম।
Walaikum